So thank you very much for the organizing committee for inviting me here. Just a few words on myself. I am a professor of communication psychology, and this is my double soul. I am an expert of technology, but also as a psychologist, I always try to put together these two fields. And also here in Institute of Sociology, I am director of a specific lab, the Applied Technology for Neuropsychology lab, that since 1995 is trying to apply new technologies in different fields, including mental health. I'm also the president of the International Association of Cyber Psychology Training and Rehabilitation, an international association whose main goal is to put together scientists and researchers in this area. Well, my speech will try to summarize my research work. I will try to tell you more about the link between technology and the body. It's, I think, a quite interesting topic, and I will try to do not in abstract, but putting it in the context, so trying to clarify how technology can be very helpful, and our clinic has a specific section with more than 250 beds for specific pathologies like obesity and eating disorders. Well, what I will try to summarize in this hour is how technology can be very helpful for these specific problems, obesity and eating disorders, that apparently are quite far from technology. Well, just a few introduction about what is obesity, what are eating disorders. Well, they are very common and social impacting problems. I have the latest data from US. You can see in US 1 person out of 4 is obese. This means that the US healthcare has to face a huge amount of costs related to obesity. But even eating disorders that are more near to psychology than apparently obesity have a huge impact on society. In US, 1 person out of 10 experienced eating disorder in their life. And also the real problem behind these pathologies is that they are very difficult to treat. I don't know, probably some of you have had a friend or family member or someone near to you who experienced obesity and or eating disorder, and you know that it's quite difficult to cope with. Why? I try to summarize the problems because I think that if a researcher is interested in providing the technology solution for healthcare, the starting point have to be the problems. So where is the problem behind the treatment of obesity? Well, 4 problems for obesity. The first one is that obesity is not simple. When we think about obesity, we think about a diet. We think about food. Well, the situation is much more complex. And what we know is that behind obesity there is genetics, there is societal influence, there is many other things. There are many other things that are not typically targeted in the obesity treatment that you can find mostly everywhere. The other problem is that losing weight is quite easy. So if you go on diet, you don't take food, well, you lose weight. The real problem is that after the diet, you usually regain all of the weight you lost. This is the real problem. So the real problem is not diet. You can go on diet. Any magazine, if you take any female magazine, once in summer, once in winter, for Christmas, you have a diet. You can follow the diet, yes, you lose weight. It's easy. The real problem is not regaining the weight after the diet. And the data from science, not from magazine, are dramatic. You can see 95% of people going on diet, not on the magazine, but in clinics, regain the weight lost in 12 months. In 1 year, you got what you lost. This is a big issue. And even more, the problem is that you find food everywhere. 50 years ago was a different. Having food was a problem. There was a war, and you know that. Now you can find food in any single place where you live. Typically, if you go in the US, in any mall you enter, the first thing reaching you is the smell of food. And this is why it's almost impossible not to eat. So together with eating related to hunger, there is a lot of eating related to smelling the food, having dealing with anxiety and so on. So the real problem is that it's quite difficult to survive to a toxic environment as it is typically defined. The other problem, the most neglected one but relevant from my presentation, is the problem of body dissatisfaction. We know that the most common issue for starting a diet is that I don't like my body. It's summertime, I have to go to the beach, I have to wear my suit, and well, I don't like my body, so I decide to go on diet. What psychology demonstrated more than 20 years ago is that if you lose weight, you don't counter your body dissatisfaction. And this is an issue. So if you go on diet, very difficult, you start a diet, you lose weight, and after the diet you look at the mirror and you say, I'm not good anymore, again as before starting the diet, you are not so happy. And typically you start disinhibition. I tried, I failed, well, at this point, why bother anymore? And this starts a vicious loop of losing weight, gaining weight, in the yo-yo effect that is considered the best common causes of obesity. Why, according to literature, the most common issue about obesity is diet. Starting a diet, losing weight, regaining weight, losing weight, regaining weight. After doing that for 10 times, you modify the metabolism of your body. Because when you lose weight, you lose both lean and sorry, my cough. You lose both lean and fat mass. But when you regain weight, you typically get fat mass only. So after 10 yo-yo round of diets, you modify your metabolism and you have much more fat in your body. The metabolism is totally modified and you are not able to lose weight anymore. This is the issue behind obesity. Well, eating disorders are not less complex. The first problem from a clinical viewpoint, I know that some colleagues in this room work with eating disorders, is that people don't want to be treated. If you have a patient with anorexia or you had a patient with bulimia, well, they don't want your help. And helping someone that is not willing to be helped is quite difficult. Again, it's not clear why we have eating disorders. There are many theories, but no one is the final one. We know that family has a big impact. We know that social relationships also have a big impact. Why someone has eating disorder, someone not? This is a big scientific problem that is not solved yet. And also, again, the main issue behind the eating disorder is the experience of the body. You know, in anorexia, you experience a fat body even if you don't have that fat body. And also the social context is so relevant that we have to understand why this social context has a so strong influence on your body, your physical body. And after just this clear picture about the problems you have to face in this field, the role of technology. The idea is, but the body that we have in this pathology, the body that we have in anorexia and obesity, is so far from technology. Well, when we think about the body, we think about physical things. We think about the skin, we think about the bones, we think about flesh. But it's true, our body is just made by bones, skin, flesh, or not? Well, the answer is no. our experience of the body is not directly related to our physical body. And we know very well, because we have anorexia. You have a very thin body that can lead to your death, but you feel your body as fat. It's not just a mental problem. For an anorectic patient, the fat body is her body. But there are some other strange, in neurology, there are many strange pathologies related to the body. The most common one is the phantom limb pain. This is another quite strange neurological problem. You have amputation, you don't have anymore the leg, for instance, but in the physical space where your leg was, you experience a pain. But how you can experience a pain in a space where there is nothing? And the pain is a leg pain. But how a physician can treat a pain that is somewhere that is not in your real body? This is a big challenge. There are some well-known scientists like the colleague Raman Shadaran working in USC in San Diego that is studying, has tried in the last 20 years to solve this problem. How we can solve a pain that is not your physical body. But there are many other. There is a quite strange problem that is called anarchic hand. I don't know if you ever heard about that. Anarchic hand is you have your hand, but your hand moves without your control. And typically, patients with this very strange problem want to do an amputation to solve it. I have my hand is moving without my will, so it's no more my hand. And there are many other strange problems. So given this situation, neuroscience try to understand some more about what is the body, at least in our personal experience. And what the new science of body is typically collected around the word bodily self-consciousness. I don't know if you are familiar with this term. The bodily self-consciousness, it's a term that describes our personal experience of the body. And we know very well that since 2007, in 2007, two different groups of scientists demonstrated on science that you can create, using technology, an out-of-body experience. So you can experience yourself outside of your body. Out-of-body experience are typically connected to drug. If you experience some specific drug like ketamine, you have this kind of out-of-body experience. Also, out-of-body experience is also described by many religions, and also it's common in near-death situation. What we know is that technology can be helpful for creating that. So the starting point of my keynote is there are problems related to the body, but the body is not the physical body. We have in our brain a specific representation of the body that is it's not localized in specific areas, but is connected. It is called in the default network, and has a specific role from a survival viewpoint, from an evolutionary viewpoint. The problem of boundaries. For our body, for ourselves to survive, we have to understand what are our boundaries. And the brain, through evolution, but also inside our history, step by step learns the different boundaries that are related to our body. And typically the boundaries are two types. The first one is the physical boundaries that are related to the physical body. And there is a representation of our body that's called body schema. And this body schema is used to define the boundaries of our body. In neurological terms, it defines the peripersonal space, so the space around the body. But there is also another interesting form of boundary that is not physical but social. It's called body image. Body image defines the boundaries not from the physical viewpoint but from the emotional and social viewpoint. So body image tells you if your body is good, is bad, if your body is inside your group or outside. And what we know is that these two bodies, two different experiences of the body schema and body image that are quite different, they involve different areas of the brain, are connected, but they influence each other. And also the interesting thing for us is that also technology influences them. And so using technology we can modify both body schema and body image, and I will tell you how it's possible to do so. The technology used for reaching this goal is virtual reality. Using virtual reality, you can modify both body schema and body image. And so this is why we are trying to use in our clinic, you know, this is an hospital. In our hospital, we are trying to use, we have tried to use virtual reality in the last 20 years to cope with these pathologies. So the idea is that virtual reality is a technology that's so powerful that is able to modify both sides of our body, both the body schema and the body image. So from the practical viewpoint, what I can do using virtual reality? Well, we can do different things. We can improve motivation using virtual reality. We can improve assessment using virtual reality. We can improve prevention and improve treatment. So the interesting point is that using virtual reality you can target all the different sides of body image problems related also to both to obesity and to eating disorder. Let's try from the first problem that I underlined before, the problem of diet. So you go on diet, you do exercise, a lot of exercise, but at the end of the diet, of your exercise, you regain weight. So what virtual reality can do for this? Well, the first issue that probably is not so familiar to any of you is that virtual reality can be very helpful to improve motivation and compliance. The idea is that using virtual reality, you have the Proteus effect. I don't know if you are familiar with this term, Proteus effect. Proteus effect is an effect that connects your own self to the avatar that embodies you. So if you have your avatar, and your avatar do some things, well, also yourself is modified by what your avatar did. And this is a well-known social and cognitive effect that was demonstrated by Professor Bailinson at Stanford University some years ago. The idea is that using avatars, you can create body self models that can be used to improve motivation. But also, you can use avatars also to provide punishment or rewards. And this is the abstract concept. In practice, there are some interesting studies made by different groups, including my one, that show that if you have a virtual avatar doing exercise, you do much more exercise. And this is not a joke. It was demonstrated by a controlled trial some years ago. So if you have an avatar that embodies your activities and do what you are doing, well, your motivation will be much more. In practice, what does it mean? If you have a virtual avatar that each day it has to exercise, it will improve the exercise you will do in these days. And this is not a joke, it's proved by scientific trials. Also, we know that this is another paper published by my team on Science in 2007. We demonstrated that using virtual groups in which avatars discuss about the pathology and not in face-to-face. For instance, eating disorder, clear problem is that you don't want to discuss about your problems with other people. But if you use an avatar that is not connected to your real body, and you use it for discussing with therapists and with other guys, well, you will do much better. You don't have any problems discussing with your avatar with other patients. So this means that using virtual reality, you can create a group session online that can be helpful for breaking resistance to treatment in this kind of patients. Another problem related to obesity is that in some patients, 3–5% of patients, obesity is connected to another problem. It's connected to the problem of binge eating. So they have it's not a problem just of overeating, but the problem is that this overeating is typically connected to emotional issues such as depression or anxiety. And if you want to treat this specific group of patients, you have to understand them and provide them not just the diet, but also psychological support addressing anxiety or depression. The problem is that people with binge eating don't tell you about that. Typically they don't tell that they have binging in the night because socially is not so well. The problem is how you can use virtual reality to solve this problem. Well, you can use virtual reality because it has a strong effect on the body image. So the idea is that this is a well-known paper in our field published by a colleague Giuseppe Maldonado in Barcelona. He demonstrated that virtual reality is able to produce emotional response in these patients that are similar to the one that you have in the real life. So this is only for patients. So if you are not a patient, you enter a virtual reality in which you have food, it's not a problem for you. But patients with problems with food that they may have an eating disorder exposed to virtual food have significant emotional response that you can track. Following this study, our group used this approach. We have a virtual reality restaurant. We exposed to patients in these virtual reality restaurants, and we connected this patient to physiological indexes. Well, the emotional responses measured using physiological instruments during the exposure to virtual food was the same as real food for patients, not for real persons. So in this way, you can easily spot, using virtual reality, who may have a problem related to eating disorder or not. The other problem is related to the issue of body dissatisfaction. This is a topic that I introduced before. You go on diet, lose weight, but this weight loss has no direct impact on your body dissatisfaction. So the body schema, because when you lose weight, you modify the boundaries of your body schema. But body dissatisfaction is in a different representation, in body image. And body schema and body image are separated, and in patients they are not connected so much. So when you lose weight, your boundaries, your physical boundaries are modified, but your social and emotional boundaries are not modified. And the problem is that if you just do on diet, you are not able to improve body dissatisfaction, and this is the real problem behind the lack of motivation in these patients. What we demonstrated a lot of years ago is that virtual reality instead modifies body image. I will tell you about this later on. But the message here is that there are many studies, and there is also a meta-analysis made by Giuseppe Maldonado demonstrating that virtual reality is one of the most effective ways to modify body dissatisfaction. So to modify the emotional and cognitive social part of our body. And this is true also for patients. We did a lot of study about that, and we demonstrated that you can use virtual reality for modifying body image in this patient. also now there is a new science, the science of body illusion, coming out recently, in which probably the two groups, the groups of Harrison and the group of Melslater in Barcelona, are the leading pioneers in this field, and both of them demonstrated that you can produce body transfer. For instance, this is a very nice paper that was published on PLOS ONE, so you can read and find it easily. This paper demonstrated that you can induce a body transfer illusion that can put a person inside the body of another person. For instance, I, as a male, can experience a body of female. And what they demonstrated, this change of the body has no impact only on your experience of the physical boundaries, but also on your, for instance, social cognition. For instance, if you enter, like you are white, you enter in the body of a black man, your attitudes towards black men will improve. And it also is a paper recently published on trends in cognitive science, suggesting that using technology you can modify the body, and using the body, the virtual body, you modify cognition. And this is a very powerful way, a totally new way of doing psychotherapy. The final part of my presentation is related to the treatment. I told you before, obesity treatment is a big issue. 1 person out of 4 in the US has this problem. The problem is that the treatment of obesity is a challenge. It's a big business because anyone has a way to treat obesity. According to some studies in the US, the diet business is 50 billion euros. A huge amount of money. So it's clear that until we don't have a clear way to cope with obesity, there any way can be helpful, and well, even if you fail, you typically blame yourself and not the diet for that. And so you don't complain with the provider of the diet asking back the money. This is why it's a very good way to gain money. The problem is that recently also surgery is having a big impact in this field. If you look at the medical journal, the best way to treat obesity now is using surgery. So this is true especially for big obesity. When you have when you weight much more than 150 kilograms, well, diet is quite unuseful. So typically you have what is called bariatric surgery. Bariatric surgery, there are many types of bariatric surgery. The most common is bending, so they close some part of of your bladder, and in this way you don't have the food intake is reduced. There are some are more radical way of surgery in which they remove most of it, but there are some problems behind bariatric surgery. The problem is that it's risky, especially for very big obese. There is some risk of dying during and after the treatment. Now is a common surgery, but there is still a problem there. And the other problem is the long term. Again, surgery is very effective. The problem is that some patients, even after surgery, are not satisfied about the body. It is a quite common problem. There is a study published recently. According to physicians, you did a very successful bariatric surgery when you are able to lose half of your excess weight. So if you lose 160 kilograms, you go down to 80, well, it's a big success. But for the patient, it's not. So if you are a female and you are 160 kilograms and now you are 80 kilograms, yes, from the medical viewpoint is totally different. But for the real life, you are still different from other women. And this is why this is producing a lot of complications and problems, even in successful patients. And you can find many comments about that. This is a post I found online on a group of patients following bariatric surgery. The basic idea behind is that, yes, she was able to successfully reduce the weight, but after that, she's not satisfied, and she is not able to address with that problem. And typically after surgery, you are left alone. The physician tells you, oh, you were able to get your goal, you are out now, but you will still have the problem of a body that you don't like. And this is a very problematic issue. So, if you want to understand some more about obesity, the best way is to understand some more about the etiology. So, why we become obese? In the last 10 years, some groups of researchers try to study longitudinal trials. So, they followed people during their adolescence, try to understand what was the critical factors producing a long-term change in the weight. This is a very, I think, important study made by a US colleague. This study tried to understand what was the most predictive factor behind obesity in a group of adolescent subjects. He tracked 500 adolescents for 5 years from the age of 11 to the age of 15. And they tracked significant variables. So if subject made use of high-fat diet, if the subject did not so much exercise, and so on. And what they discovered was that the only factors, the most significant factors inducing obesity in the long term was diet. If you, at the age of 11, went on diet, at the age of 15, you have a significant probability of having obesity. So it's not doing not so much exercise or having a wrong diet, in the sense that you have too much high-fat food. The most significant factor was diet. And why they went on diet? Why an adolescent, pre-adolescent of 11 years old can decide to start the diet? The problem is the same. I am on diet because I don't like my body. So the problem is that this study, but many other studies, clearly show that body dissatisfaction is the basic problem behind these kind of issues. At 11, I go on diet just for one reason, because I don't like my body. This is the issue. And diet, unfortunately, is not able to solve it. This is the critical problem. And there are many, after this study that opened a new line of research, you can see any area of weight-related disorder was studied using longitudinal research. You can see easily in obesity, in binge eating, in anorexia. The problem of body image was the starting point. Unfortunately, there are not so many therapists addressing this issue in the real life. So if I have a body image problem, where I have to go? If I have a problem with my body, typically I go to the nutritionist, to the endocrinologist, sometimes I go to the psychologist, but not so much. So the real problem is that body image, that is distorted body image, that is the leading problems behind these pathologies, is not addressed by the typical treatment. And so the idea is body image is the real problem. However, there is an important comment made to this. We know that body image is the problem behind eating and weight disorder, but we also know that almost any female adolescent has a problem of body image in her life, but not all of them then have eating disorder of obesity. So, yes, it's true, body image is the starting point, but cannot be the only critical factor, because many female subjects experience body dissatisfaction in their life, but not all of them become obese, become binge eating, become bulimic, experience eating disorder, and so on. So, why only few of them move on to a clinical pathology? Well, this is the work, one of the part of my research work. In the last 10 years, I try to understand what is behind. So, I am sure now, but not me, the scientific literature that is sure that behind eating disorders there is a problem of body image, but cannot be alone, because someone, not anyone, experiences this problem. So the idea is that if we have to understand some more about this issue, we have to understand some more the neuroscience of body image. I will try to summarize. I told you before that scientific research identified two different representations of the body. The first one is called body schema, and the second one is called body image. And this is true also for the representation of spatial representation of the body. So we have two different ways of representing your body that they are presented here using two different video games. The first and the native way of experience of the body is the egocentric way of measuring of experience of the body. In the egocentric viewpoint, that is the similar any first view shooter that you can experience, the space around you is modified by the movements of your body. So the idea is that you have a representation of the space that is linked to the main axis of your body. So when you move, the space around you changes. This is the first experience of space that the children do when they are in the first months of life, and is very helpful when you want to do actions. So using this representation, you can pick up things around you. The real problem is that this way of addressing space has a problem that changes every time you move. And you, in your life, you need maps in order to find the right path in situation when you are not, you don't have a previous knowledge of the space. So you also represent space in the second way, like for instance Pac-Man. The space is fixed, it's you that move inside, but the representation of space is the same. And like body image and body schema, these two representations of space are separate. They are not. They are addressed by different areas of our brains. The problem is that we have to mix them in some way. And the idea that I'm working on with my team is that in a patient with eating disorders, obesity, there is a problem in connecting them. So this egocentric representation of space and this allocentric representation of space are no more connected. And this produce a very simple problem that I'm telling you. Well, I entered a diet. Well, I'm step back. I look at myself at the mirror. I look at myself, I find myself fat. I don't like my body. So I decide to go on diet. The good thing is that I start the diet and after this successful diet, I suppose that your diet is successful, your legs, when you started to look yourself at the mirror, you don't like your legs, typical body part that usually is not liked so much by girls, and after the diet, the legs, the physical legs, reduce the boundaries, so they are thinner now. The problem is that you have a memory of your body stored in your brain. This memory is not stored in an egocentric viewpoint, but is stored in an allocentric way. So you look at yourself outside, like in the mirror. When you look at the mirror, you look at your body from outside. When you look at your body here, you look from inside. So you have your memory of your body from outside that has to be updated with the information coming from your senses. And this is made in a specific area of memory that's called working memory. In working memory, if you want to update a memory of your body that you have stored in an allocentric viewpoint, you have to connect them. The problem is, if you are not able to connect and to put together this stored memory of your body that is from outside, your memory in front of the mirror, and the memory that you have from proprioception coming from your body from inside, well, the real problem is that you don't have the possibility of updating it. So, even if your body, physical body has changed, your mental body is not updated. And so, even if you were successful in obtaining this change, well, your memory of the body is still there, is not changed. So apparently, behind eating disorders and obesity, there is a specific problem that is connecting the two sides of our representation of space, from inside and from outside. And the problem is that if after a diet I'm not able to achieve my results, well, I keep on going. And probably I can try to lose more and more weight. I can become anorectic or do the opposite. At that time I tried, I was not successful, I start disinhibition, so I will eat anymore. Depression, anxiety, frustration push me to eating anymore and more, and I will come obesity in the long term after many cycles of diet and gain weight. So the idea is quite simple. We have two different representations of the body. The first one is the one from inside, looking at you as you do every day in your life. The other one is in the mirror. These two representations are connected in our brain and interact in the working memory. If for some reason this connection is not more working, well, you are not able to change the second one. You are still locked to a memory of your body that you had in the past. The same old negative body that you don't like is still there, and push you to keep on working on your attempts or not. The interesting thing is that virtual reality can connect them, and this is the interesting part of my talk. And technology is very helpful in doing that. So what we have done is quite simple. We use a simple approach. We integrated the typical approach that you have in an eating disorder and obesity. The most common treatment is cognitive behavioral therapy. So what we have done is using cognitive behavioral therapy for solving the typical problems. But to cognitive behavioral therapy, we added specific sessions of virtual reality. I try to move. So this is a typical cognitive behavioral treatment approach. So if you are obese, you have to do physical exercise, you go on diet, the typical stuff you do in for this patient. But what we did was adding what we defined a virtual reality rescripting protocol. So the idea was trying to connect again the two different parts of the body experience. The protocol that you can find here, you can find on the many papers I wrote about this topic, is quite simple. The idea is, let's try to understand the memories. When you got your negative memories of your body. For many patients, this happened typically in adolescence and was related to teasing. For instance, your boyfriends at school told you that you are fat. And this is the memory of your body that you remember. So we ask to the patient to identify the most negative memory of the bodies coming from the real life. Then, using virtual reality, we have created this NeuroVR software, a free virtual reality software that allows to reproduce typical scenes of real life. We will try to reproduce the setting. So, for instance, if the patient was teased in the classroom, we will try using this approach. You see, Lego approach. You can put together. We have created different predefined scenarios, so a school, office, home, restaurants, and so on, so you don't have to bother with doing 3D modeling. Then you can put real images of patients on the familiars and so on inside. And what we did is simple. So first we reproduce the scene from an egocentric viewpoint. You have, for instance, in this case, the student teasing you, and you look at him and you reproduce the situation. And in this situation, you use some typical cognitive behavioral approach, countering, level shifting, that are used to cope with the negative emotion induced by this situation. In the second part, you see your body discussing with the boy, and you have to help your body from outside in coping with the negative experience made by the subject. So the idea is that we put your allocentric memory again in the flow of experience, try to see if this way we can connect this stored memory, change it in some way. Well, we tried this approach. We controlled trials because we know the mechanism is quite simple in itself, but to test the efficacy, we used different clinical trials to verify if, randomized clinical trials to verify if we were able to change the situation. We have two different groups. The first group is composed by 163 obese female patients, and the second one was composed by 71 binge eating disorder patients. This is a randomized trial in which we had a waiting list. We have a group that made just diet or physical exercise. We have another group having cognitive behavioral therapy, and the final one in which we also had the virtual reality. Both of them are published, so you can find them in ResearchGate if you want to read. This is the first one. We tracked the experience of this patient for 1 year after the treatment. And what we discovered? What we discovered that, well, when you enter in the treatment and you finish the treatment, all groups of obese were able to lose the same. So at start, there is not significant difference between the groups. The critical difference is in the long term, and you can see here. If you look at the first table, is the group of subjects that were able to maintain and to improve weight. You see, if you just do a diet, only one was able to maintain the weight loss. If you have a CBT, you have 11. If you have a virtual reality, almost half of the patients were able to retain the weight loss after 1 year. That is much better than typical outcome you can find in literature. And the same if you see at how many were able to not improve anymore. If you look, you see that a lot of patients who did just nutritional treatment, well, they gain more weight after 1 year than the weight that they had at the start of the treatment. This happened only on a small subset of groups for virtual reality. A similar approach for binge eating. Also, this is another randomized trial, the same 1 year follow-up, and the same approach. We see that in binge eating, another critical problem is that binging, that you have binging all over the day. You can see here the same. Binging where virtual reality was more effective in reducing the level of binging. So this demonstrated that this approach, virtual reality, significantly improved the outcome of the treatment against the gold standard of the therapy in this field, that is cognitive behavioral therapy. However, you have seen from the table, not any patient was able to achieve a significant improvement using virtual reality. Our hypothesis was that this change was related to the virtual reality experience, was not so strong to modify the experience of the body. So recently we decided to do another approach, virtual reality body swapping. So the idea is, if we just put the patient in a different position again, towards the body, can be effective for not so critical patient, but is not so effective for very critical patient. For this kind of patient, we have to radically change the experience of the body. So what we did was creating this virtual reality body swapping protocol. Virtual reality body swapping is quite simple. We create a body that is quite different from your one. In this case, we use a very thin body that is very similar to the body of an anorectic patient. And using this approach, the body illusion, we put the body using virtual reality inside this specific body. From the technical viewpoint, it's quite easy. I show you for obese patient, because we test this approach also with a very super obese patient. The mechanism is this. What happens to a very big obese patient, 60 of BMI, that means more than 200 kilograms, inside the body of an anorectic girl? What is interesting is that the mechanism is the same. You have a virtual reality headset, you look at your body, and you see in virtual reality that your virtual body is touched at the same time that your real body. After doing that for some time, you consider that the visual information coming out from the virtual reality overrides the information coming from proprioception. It is quite impactful for this patient. The problem that it was that this very super obese patient had a problem with the body. So that was the opposite of the anorectic. So she is very obese, but she's not experiencing as her body as very obese, so she's not motivated to go on diet. You see the abdomen. For this super obese, this is the ratio between the real body and the experienced body. For this super obese patient, this woman experience the size of the abdomen half the size of the real abdomen. And the problem is that she is not willing to do treatment. Using this approach, in which we put ourselves in a different body, you see that we were able to modify significantly the experience of the body. And we were able to improve the experience of the body in order to make it more realistic. This suggests that using this approach, you can produce more radical changes in the experience of the body that maybe, this is our next challenge, you can use them for improved long-term treatment of this pathology. I have not, my retirement day is 20 years, so I have a lot of work to do yet. And this research is suggesting you a new path for mental health, the idea of embodied health, the idea that we can use technology for radically improve and change the experience of the body. We know from psychosomatics that there is a direct link between the experience of the body and our brain. Our feeling is that using this kind of bodily illusion, we can in some way modify medicine. Up to now, medicine tried to work only on our physical body. The challenge in the long term, also for you, some of you are very young, is try to work also on the mental body. And technology is one of the best ways for doing that. So the next challenge for 5 years is trying to understand, developing a technology that is able to modify all the sides of the experience of the body. In virtual reality, you typically modify the external experience of the body. You modify the visual part and also the touch. But we know from neuroscience that also proprioception, interoception, the vestibular system that is in our hair have a critical influence in modifying the experience of the body. So the idea is that using the technology, mixing together virtual reality with haptic system, with different brain stimulation technology like TDCS, non-invasive or TMS, we can influence all the different parts of the experience of the body and in some way identify new approaches for mental health. The final challenge when I will retire is the matrix training. This is my dream. If you have seen the Matrix movie, you know that the hero was able to learn to drive an helicopter just plugging his brain to a computer. I think that it's not impossible to do so. If we are able to use technology to modify our experience of the body, we use technology to simulate the somatic experiences that are used to learn most of the practical activity, driving a car. Imagine if we can learn to drive a car not going to classroom, but just having a simulation of the skills required to drive a car. This is Matrix. Well, I hope that you and me will be able to achieve that in a long day, but not so long. Thank you very much for your attention.